Hi, I'm Betty Keller, President of the Vermont Physicians for National Health Program, and I'll be moderating our panel this afternoon on state-based universal healthcare reform. Delighted to have three panelists with us here today. And I'd like to first introduce Warren George. And Mr. George, if you can wave your hand so they know which one you are. Thank you. He was the director of primary operations at a Fortune 500 titanium production company, and following that, he was a financial management consultant for a dozen years. He's given over 60, that's 60, presentations on funding universal health care. He was a governor-appointed member of the Oregon SB 770 Universal Healthcare Task Force, which met from 2020 to 2022. And served as the vice chair of the current SB 1089 Universal Health Plan Governance Board during its launch in 2024. And Joe, if you can raise your hand, let people know who you are while I'm introducing you. Thank you. And Dr. Jarvis is a medical doctor and Master of Science in Public Health. He completed postgraduate medical training in family practice, public health, and occupational medicine. In addition to its primary and tertiary clinical care and public health consulting, Dr. Jarvis has been a faculty member and teacher at the University of Nevada School of Medicine and the University of Colorado Health Sciences Center, as well as a state and federal public health official in both Nevada and Colorado. He's an author of numerous peer-reviewed articles, published 4 books, and produced a film. Dr. Jarvis has advocated for single-payer health system reform for 30 years and currently chairs the Utah Cares Political Issue Committee. And now I'd like to also introduce Melanie D'Arrigo. Am I pronouncing your name correctly? Close enough, sorry. Ms. D'Arrigo is a native New Yorker, mother of 3, and a former congressional candidate. She spent her career as an allied health professional, building preventive health strategies and programs for organizations throughout the U.S. Melanie is a leading voice for universal healthcare in national politics and currently serves as the executive director for the Campaign for New York Health. And I introduced her last because she'll be speaking first. So we're looking forward to having presentations, 10-minute presentations from each of our 3 speakers, and then we'll be taking questions after that.
Would you like me to begin, Betty?
Please.
Okay, great. Well, thank you so much, everyone, for having me here today. It's a real delight to be here. I'm very excited to see so many of you as part of this incredible internship and your interest and passion in single-payer healthcare. Lord knows this is the time. We certainly need it. So I'm really glad to be here with you today. As Betty said, my name is Melanie D'Arrigo. I am the executive director for the Campaign for New York Health. We are a statewide coalition dedicated to passing and implementing the New York Health Act, which is our single payer bill within the state of New York, which of course would guarantee comprehensive, high quality health care to every single New Yorker. Our coalition is quite broad. It is comprised of 501c4s, 501c3s, grassroots organizations, faith-based groups, local activists, advocates, labor unions, et cetera, et cetera, et cetera. Thankfully, we are a growing coalition. We've been around for, a good amount of time, but it certainly feels like there is certainly a pressing on the gas kind of moment in these last few months leading up to this disastrous reconciliation bill. We've had folks pouring in from around the state to get involved with the campaign and so many of our coalition partners as well. And I do want to just give a special shout out to PNHP Metro Chapter, who is one of our most active coalition partners. They're incredible and they do a lot of work with us, virtually every week. They do a lot of their own programming, but we do a lot of programming together as well. So, this is a coalition, of course, all united in the pursuit of single payer healthcare. And I think, it's been a coalition that has I think waxed and waned, for better or worse. It's very difficult to continue to maintain a very large coalition when the media landscape is constantly changing, right? So the last couple of years, there's been a lot of focus on housing, another very important issue, but more so lately because of, again, the reconciliation bill and the threats to Medicaid. Healthcare has been top of mind, right? And so what we've seen is not only individuals pouring in, but new organizations wanting to partner with us and are more interested and curious to see what we're about and work with us. And interestingly, and this sort of leads me to, who we are and what we do. We've even seen an uptick in labor, right? And folks that historically have not wanted to interact with us. I think the changing of health policy on a federal level, while it's horrific and awful, and I wish it weren't so, but we are where we are. It has allowed us, from a state perspective, it's certainly opened more doors, and I think that our coalition will end up being a lot stronger, and I'm very hopeful for the movement that we will make coming into this next legislative session here in New York. So, our coalition, our campaign, what are we about, right? We do quite a lot, but we're primarily focused on three areas: building labor support, building more support around the state, and building stronger relationships with our legislature. So I want to talk for a moment about labor. Historically, we have had a little bit of trouble with certain labor unions in terms of supporting single payer, which is somewhat ironic because we were actually founded, we wouldn't exist without the New York State Nurses Association, which of course is a large public nurses union in New York. They are the ones that went to Assemblymember Dick Gottfried, who's the original author of the New York Health Act, and convinced him to write the bill. They are a founding member, or they founded our organization, and they are our largest supporters by far. So it's interesting, right? I think it highlights the fact that no group, no one demographic is a monolith, right? And we are all different, have different priorities. But I'm proud to say that through a lot of diligent work, hard work, partnership building, and I think a little bit, as I mentioned, that the changing of the times, we have been able to bring in more labor into our coalition than we've had ever before, which I think is exciting. We have 1199 who supports us, CIR, Doctors Council, of course, UAW, they've been supportive, but they've come into our coalition in a major way this year, showing a lot of enthusiasm and support. And if you're familiar with UAW, I don't know how many folks are, they are, I think, one of the more exciting unions right now in our country, really showing a lot of courage, really being unafraid to get out there and support policies that benefit people. And that's, I think, unfortunately becoming more and more rare. So it's exciting to have them in our coalition. We've also recently brought in RWDSU, the retail workers, and I think, we're going to continue to grow. As I mentioned earlier, there had been previously unions that didn't want to speak to us at all, and now we're having conversations, right? And I think it's important when we think about progress, right? I think all of us have the goal of single payer, and that is our main goal. But it's important with, a bill that is as transformational as this one, right? That we also celebrate the other wins, right? There are many, many, many wins along the way to achieving our main goal. And I think this has been an area that's been a little bit elusive in terms of how we build labor support. But I think it's very, very exciting. We also have coalition partners that are actively organizing within rank and file labor members. And I think that shows a lot of promise. So, it's not just a top-down approach. It's sort of like we're sandwiching it and we're attacking it together. And I think, we're always looking for more creative solutions there. But, it has led us to this moment where we have now developed a labor coalition. And not only are, some of our labor supporters active within our campaign, they're now looking outward to help make introductions and bring new labor unions within. So I think that's going to be really critical as we move into, move through the summer and into the next legislative session in New York. That is a big one for us. That is, I know that changes. That's not universal across all states. Some states have unions that are all in. In New York, it's been a bit more challenging, but we're very excited about the progress, and that is one of our main focuses. Secondly, and I think this is where the bulk of our work has been done. When I say, we're looking at, and our focus is building support around the state, that is done in several ways, right? Certainly, we're very focused on education. In the last year or so, we have kind of taken a little bit of a more, I think, strategic approach where we are actively building out regional hubs in every corner of the state, and then utilizing those regional hubs as anchors for new folks that are coming into our movement. So we have obviously a centralized campaign, but to have these kind of satellite hubs around the state helps folks better connect with their communities. It's obviously always better to interact with someone in your community or community over than someone who lives on the other side of the state, right? And I think those partnerships are really important for longevity and momentum building as we kind of push through. So our regional hubs are another major priority for the campaign. We're very excited that we've got a lot of active supporters who are now really stepping up to take on leadership roles. And these are not folks who are trained organizers, right? So a lot of the times they're coming in and we're training them and giving them that training on how to organize, how to do, New York Health Act 101s, how to do outreach, how to speak in public, how to speak to press, how to write press releases, et cetera, et cetera. So there's a lot that it entails, but I think it's really rewarding and beneficial because we are really investing in these hubs, right? So that they can then take that and further invest in their communities. And we really believe that that is a critical component to success. And let me see where we've ramped up our programs. As I mentioned earlier, PNHP Metro, they've been a great partner. They do pretty specialized programs every month on the New York Health Act or a component of the New York Health Act. So sometimes it might focus on the long-term care component. It might focus on financing, right? Always looking at it from a different angle. We've started to do a lot more New York Health Act 101s as well, because, once we've got folks engaged, I think, those specialized programs keep people in the program. But there is kind of a high barrier to jump in and understand this, right? As folks in medical school, I'm sure you realize that the average person really doesn't quite get how to navigate the healthcare system, right? What's a deductible? What's an out-of-pocket max? Right? It's very difficult. So we really have developed, our real goal has been to reduce and lower that bar to entry so that we can bring folks in so that they can understand the facts, and then we bring them along a continuum. And so that's been, I think, also very rewarding. Through that, we've developed an education team. So as folks are coming in and, experiencing these 101s, if public speaking is a interest of theirs, we train them to then be educators in their communities as well. So that's been, that is the bulk of our work, I think, for sure. But it is so critical that we continue to spread the message. What we find in New York is that many of our residents have heard of programs like Medicare for All, which is not unsurprising, right? In the 2020 primary was the very first time they were debating single payer on a national stage. That was really exciting, and I think it helped spread the message. In New York, we find that people have not heard of the state-based bill. So they know about the national one, and they need to know about the state-based one. So that work is really, really critical. And what we do find is that when people learn about it, they're all in. Particularly in the last few months, we're getting very, very little resistance to the idea of, transitioning our broken healthcare system to one that works for all of us. And then lastly, we have a strong legislative component to our coalition. We of course have lobby days, individual lobby meetings, where we spend a lot of time training supporters and advocates on how to have lobby meetings, and we really walk them through that process, and that's of course very critical. We do mass mobilizations, mostly in Albany. I think this year we're planning to do many around the state as well as we ramp up our efforts. But we also do a lot of individual legislative relationship building, right? Because we have currently right now, we have majority support in the state Senate. We're one away from majority state support in our state assembly. We had a lot of folks move around in this past election, so we lost like 10 co-sponsors, but we'll get there very soon. But what happens in New York is that it's not a straightforward process like folks would like us all to believe, right? There are many variables in the political process. Certainly labor is a piece, PACs are a piece, the insurance industry is a piece, the hospital industry is a piece, pharma is a piece. And then there's, resistance to change. So we have found that while we do and historically have had majority support, the bill has still not moved. So that has been a real challenge for us. So we've been very focused on creating what I like to call individual pressure systems, right? So if there are key legislators that we need to move, we're very strategic in terms of figuring out which are the variables that we can manipulate to pressure them the most. And sometimes it's constituents, sometimes it's leaders in the community, sometimes it's other members. And so that individual relationship building with state senators and state assembly members is really, really critical for us. We strive not only to, although of course, at a minimum, we want majority support in both of our chambers. What we strive to do is move them from supporters to champions, because that's really where the rubber meets the road, as they say. So a lot of our work is focused there as well. But I think, as I said, this is a time where people, regular, normal, working people, are paying attention to healthcare issues. More than ever before, I think, even more than during COVID, right? Because during COVID, we were scared, right? We were Cloroxing our bananas and we were afraid we were going to die, right? That was the reality of COVID. And it was very hard for people to take an action when you're so scared. When you're frightened, you really go insular. But what we're finding in this moment is the opposite. People are angry, and we are trying to help them channel that anger into positive action. And I think that, I always tell folks when they ask me, when are we going to pass it? What are we going to do? And we have wonderful folks in our coalition and really the most passionate, morally compassionate people that I've ever met. And when they say, well, we've got majority co-sponsorship, what's going on? Why can't we do this? And, I always tell them, we have always had the moral argument, right? And then we've had the fiscal argument, right, for passing this bill, but we have never quite had the right political moment. And that is a really huge piece that I think we often overlook as activists and as people that care deeply. But now, perhaps for the first time, that political moment is here, and it is incumbent on all of us to seize this political moment, because I promise you it does not come around very often. So now is the moment to charge. We're going to take all of our efforts and double down on them and grow as fast as we can, and we need everyone's help. So wherever you are, if you want to help us out, or if you've got a state-based bill in your state, I encourage you to please get involved. All of us, I think I can say confidently, I think so. Certainly this is true of New York. We're all ridiculously underfunded, right? And we're underfunded because we are an organization that is fighting for people. We're not an organization that someone's going to get a big payday at the end of this, right? So those groups, they're not giving us any money, right? And it's hard. And this is real grassroots movement. This is real grassroots work. And it is, it's the people's work, right? So, but I can't stress it enough. This is the time. So please get involved. And with that, I will hand it back to you, Betty. Thank you so much. And I'll, of course, stick around for questions.
Thank you so much. So if we could have Mr. George speak next, that would be great. He'll be speaking about Oregon's state-based plan.
Thank you, Betty. And I have a few slides just because, like an Italian who can't talk without their arms, I have difficulty speaking without at least something to make my face smaller. Uh, um, so I assume that most of you have seen a presentation by Dr. Chun-Wei Chi. He's a current member of the Oregon Universal Plan Governance Board, now in its second year. I'm filling in. He's in Taiwan. I served as vice chair for most of the governance board first year. Dr. Chi has been a delight to have on the governance board because of his concentration on establishing the steps of establishing community norms and making systems follow community norms, and his experience contributing to the development of the Taiwan system of universal care. Presumably, you've seen his talk for this panel discussion. I'm just giving a quick update related to the second section of his outline, Oregon's Path to Universal Health Care. Joint Task Force on Universal Health Care, which met from 2020 to 2022, on which I was also on, was by far not the first Oregon effort or study, but has been among the most extensive explorations into universal care. With over 100 meetings, dozens of expert consultations, task force did not complete the financial part of its task, which is actually the hardest. As a member of that task force, I helped to write a follow-on bill creating SB 1089, Universal Health Plan Governance Board, as created by the legislature to start from where the task force left off, concentrating specifically on the full financial and operations plan to make universal care a recommendation to the legislature and the governor. Here is a diagram from Dr. Chi's talk showing SB 770 task force, how that fed into the 1089 governance board, and which will culminate in its recommendation to the legislature and governor September of 2026. I can argue that his diagram leaves out an important step. The legislature would be extremely unlikely to implement a publicly funded healthcare system, particularly of the size. You stop and think about we're creating an entity larger than any corporation in Oregon. Nike is our largest corporation, and our single payer would be a larger organization than Nike. So it's going to take a lot of work and a lot of detail. And I can guarantee you that the voters are not going to just let the legislature or the governor implement it without a statewide vote. I like Dr. Chi's depiction of some of the high-level components and decisions which need to be decided by the governance board. To date, there's really only one decision that has been made more or less irrevocably, and that is that the state single payer will be operate as a public corporation owned by all the state residents, but otherwise outside of state government control. Other decisions, such as covering all state residents and covering all services, will require more detail. And that detail is, in Oregon, we have a problem that have about 300,000 people who cross a bridge between Washington and Oregon to work in Portland. And, how will those people get their health care? We made an early pledge that says that employment status will not affect your eligibility for the plan. But yet if we cover out-of-state residents purely based on their employment, seems like we're violating that standard. And, what services will be covered, it's the way that the governance board is working is let's work first to figure out how much money we have, and then what's the best way to spend that money. Here is a timeline of the progress to date of 30 months total when the governance board began. There's less than 14 months remain, and a lot of work to do. Now, moving on from specific to the Dr. Cheese talk, the Oregon has had significant advocacy since the 90s. We put together Measure 23, which was a complete, mostly a single payer plan in 2002. A lot of us put a lot of work into that. It failed 21% yes to 79% no. Of course, that took a lot of the wind out of advocacy for a number of years. We advocate organizations funded studies by Gerald Friedman in 2013 and 2015. We have done, actually, this is our third state paid for concept study. The legislative work group funded a report by RAND in 2017. The task force had some actuarial work done by CBIZ Optimus in 2022. I wish I could tell you who the contractor for the governance board is going to be. I think it's going to be Milliman, but last I knew the contract was not signed. So the kind of the big uphill from here is actually for the governance board itself and somewhat the advocate community to make some important decisions on the financial plan. And there's really, when you end up going to the ballot, one way or another, the state is going to do some sort of financial impact or fiduciary study of its own, which advocates, if the studies, if the preparation studies are done in a way that involves some of the state people, or anyway, it's not a trivial battle. Of course, the taxes are the hardest things, and one of the reasons that we have never gotten past that. There's always the hope that you can negotiate the tax onto someone else. And thus far, it's very difficult to get people to step up and say, I'll pay the tax, which I'm very much in favor of as a civic leader. I think we should all step up and pay the tax. But yeah, getting someone else to pay the tax is a problem when there's nobody here but us. One of the things that I think was really important in the failures in Oregon and Colorado is failure to recognize that we're talking about a cumulative tax of possibly 16 to 18%, and so you compare that with what's the biggest programs that have ever been put in place, and Social Security and Medicare are two of those. Well, it took 50 years for those taxes to gradually ramp up. They started with a 2% tax. So, one of the things that we recognize that we're up against is this kind of sudden sticker shock. Even though people may be spending 20% of their income presently on premiums and out-of-pocket expenses, a 16 to 18% tax, even though they're saving money, is easy, creates fears that are easy to exploit. So here are just a few challenges of the existence of a statewide vote creates actually a major question, and it's one that the governance board is dealing with. Do you design a plan that you want and then figure out how to sell it? Or do you go out to the voters and say, we've got a big problem here. What are the ways that you would consent to participating in solving it? And depending on, which of those two approaches you take, a couple of years ago, I was honored to have a debate with T.R. Reid of Colorado, whose 2016 measure also went down by 21% in favor, 79% opposed. There's some people that the more detail you give them, the more they run away. Other people who will not vote for it unless the details are clear and plentiful. Of course, everybody's got to deal with federal permissions and approvals. A couple of the things that the state of Oregon is dealing with, and it's both in the advocate community and the governance board. What are we doing here? Are we trying to save money for the people who pay for healthcare? And that is kind of difficult when 5 of the 9 members of the board are either physicians or leaders of advocate groups for mental health or other issues. So currently, even though Oregon has advertised for 15 years that people would save money, the current mood of the governance board is to spend all of that money on increased services and increase provider wages where shortages exist. And of course, then there is a conflict between lowering total cost or transferring the cost onto others. And one of the things that's not talked about often enough is taking, if we could get like a 10% cut in the total cost, how do we preserve that forever? How do we get everybody, all of the people involved in healthcare to live within the income of the community? So that's the end of my talk. I think the mood in Oregon is, we're excited to have this process ongoing, but there's also challenges. I put my email address on the bottom and I welcome correspondence. Thanks, Betty.
Thank you so much. And so will you have these slides? Will you email them to me so I can get them available to the students?
If anybody wants them, they can email me. I don't think there is anything tremendously earth-shattering, but if you see something, I'd be happy to share them with you.
Okay, thank you. Thank you. And Dr. Jarvis?
Hi, thanks for inviting me to speak about the single payer movement in Utah. We have been actively considering how to put a policy together for Utah's single payer since about 2021 or 22. About a year ago now, we managed to find one member of our legislature who was interested, and he agreed to open a bill file for us, not with the object of going to the legislature and trying to actually pass legislation, because unlike New York and Oregon, the Utah legislature would never have allowed such a bill to get even to hearing, much less to some kind of vote for passage. Rather, to use the Legislative Counsel Bureau, the attorneys who work for the legislature, to draft the legislation for us. We had developed a policy a proposal for how to create such a single payer. We meaning the group of us who have been working together for several years, mostly physicians, about half and half retired and actively practicing. And then a number of other interest groups, including the Utah Association of Community Health, for instance, had joined in on that policy process. During the policy process, we raised enough funds so that we could hire people like Dr. Gerald Friedman in Massachusetts to help us with some economic studies. Our first study was actually conducted by the University of Utah, and Dr. Friedman's was the second study. You have access, I believe, to both of those studies. And if you haven't seen them, they're on the website that I currently manage with others, and that is utahcares.vote. So we used those fiscal studies to begin the process of drafting the legislation, which did three major things. First, it transformed an entity that already existed to pay for healthcare for public employees and their beneficiaries. We transformed it to a universal payer for health services. We chose it because it already exhibits the very efficient behaviors that you would want and expect from a single payer. They don't try to make a profit. They are publicly owned. It's a trust fund. They are, have a very low overhead, something on the range of 4%, compared to the usual nonprofit health plan located in Utah running 20% overhead. So we saw in it the behaviors that we thought would be good to replicate beyond the 200,000 or so members it currently had to the 3 million plus Utah residents that exist today. So that was number one thing that the legislation did, is rename and recreate that payer. It's called today Public Employees Health Plan, and we renamed it Utah Cares. The statute that we were drafting, we called the Utah Cares Act for that reason. The second thing we did was create a governing board that would supervise the planning and regulating and adjudicating associated with health system function. The payer would be responsible for negotiating directly with hospitals, physicians, and other providers of care. And in the case of hospitals, negotiating a budget, an operating budget, and paying them not on a fee-for-service basis, but on that operating budget basis, so a monthly check. That was the payer's responsibility, or Utah Cares responsibility. But the board, which we called the Utah Health Systems Commission, was responsible for defining the benefit package and keeping it up to date, recurrently defining it over time, for budgeting, for keeping very clear about what the revenues are that were coming in and whether those revenues were projected to meet the needs of the healthcare system. There are always conflicts associated with healthcare delivery, malpractice, et cetera, and there was going to be an adjudicatory function in the commission, similar to workers' compensation in the Labor Commission in Utah. So not without jury trials, without punitive damages. So relative low cost adjudicatory system. Now that was number two. Number three was to actually create the funding mechanism. Dr. Friedman, when he gave us his report, he offered what he considered to be the various options for funding Utah Cares. And he came up with some of the usual things you've heard reference to already. That includes payroll taxation, sales taxes, property taxes, income taxes, et cetera. These are taxes that already exist in Utah. And so you would have to add on to what already exists an amount equal to what you needed to fund Utah Cares and finance all the medically necessary care through the state. It became pretty clear to us right off the bat that Dr. Friedman, coming from Massachusetts, had relatively little expertise in Utah's taxation system. And that was a problem because when he started recommending, for instance, income taxes, he was ignorant of the fact that income tax was created by constitutional amendment in Utah a number of decades ago. And that constitutional amendment designated all revenues from income tax to go exclusively to the education system. Well, there was no way to use increasing income tax as a way to fund Utah Cares. Therefore, we decided we needed to ask a local group with economic strength, and that is a group that knew their economics, but also that knew Utah's tax policy. And we found such a group called EconoWest. The principals had all served in various capacities in public entities in Utah, including the Utah Tax Commission and the Office of the Fiscal Analyst for the Utah State Legislature. We asked them to look at all possible means of taxation, everything, put it all on the table, and then come up with their recommendation in terms of something that would be broad-based, because as Warren just said, everybody should pay for healthcare. It's not something that ought to be foisted off on the cigarette smokers through a tobacco tax or, some other group. We all need healthcare. We all feel like we deserve to have it. At the moment when we are injured or ill, we seek it. We therefore should all pay for it. We were also trying to create a system that required very little, if any, payment at the time of service. We wanted this taxation system to prospectively pay for things without having to come up with something that would interfere with the delivery of healthcare because of point of service payments. So our EconoWest group started out by getting together with Dr. Friedman and hammering out between the two of them exactly how much that money the proposed Utah Cares system would require. That was a fairly difficult moment of negotiation. Happened about exactly a year ago. The amount that was predicted to be needed after you looked at what Dr. Friedman predicted as savings, and the savings he predicted amounted to some total of about $16 billion over the way business had traditionally been done in healthcare in Utah. And also the amount that was going to be spent more because we were going to finance care for those who were uninsured. We were going to finance care for people who were underinsured, and therefore there was going to be an increased demand related to care. And we also wanted to pay more. We didn't want to pay more than Medicaid had been paying providers. So we had to subtract off from the savings that we anticipated those extra costs that we also anticipated. And that required a round of negotiation, and eventually they came up with a figure of $10 billion is what we needed to raise. Essentially what that is an amount of money that's raised to replace what private employers are currently bringing to the healthcare system. They are, of course, bringing it to the healthcare system and then taking it as, in part, from off their federal taxes to some degree. They get the advantage of the federal tax benefit given to healthcare benefits. But nonetheless, that's an amount of money that streams into the healthcare system initiated in the private sector like that. We didn't feel like we needed to replace all of the money that's currently brought in that way, which is somewhere upwards of $15 billion a year, but we just didn't know how much exactly it would be. And as I said, the negotiation ended up with a figure of 10 billion. That is a remarkably large amount. Just to put that in perspective, historically, Utah's income tax has derived $6.5 billion per year. Sales taxes likewise are in the range of about $6.5 billion per year. The total amount of state taxes raised every year is $16 billion. So we're talking about something that's not quite as big as the total amount already taken, but it is a significant chunk of that. And it would raise the total amount of taxation going to the state of Utah quite substantially. So taking all that into consideration, EconoWest, our consulting group, offered up several possibilities. One of the early ones they talked about was a value-added tax, such as is commonly done in Europe. We declined to use that method because value-added taxes are not all collected in the home state. Some of the value added would have to be collected out of state, and that we thought was not simple or reliable. We needed something that was already pretty much part of the healthcare or of the taxation system, like property tax. Everybody understood it, it was already done, but something new. The other tax base that's on the same order of magnitude as the value-added tax is the gross receipts tax base. Gross receipts is a term for how much money exchanges hands before you take out expenses. So if I'm a consultant, which I am, and I have a client pay me $100,000 for services, and without including the cost of providing those services, that $100,000 is my gross receipts. And so that tax base, because it doesn't include all the expenses, is a fairly large one. In fact, it's probably the largest tax base. And therefore, the percent you levy against it in order to raise $10 billion is relatively smaller. We didn't want to harm businesses, and so we started being interested in the gross receipts tax and asked them to pursue it. We wanted to try to protect smaller businesses from harm. We didn't want them to have a gross receipts tax that exceeded their basically what they were going to make, and therefore basically the gross receipts tax would put them out of business. We didn't think that was right. We needed to try to avoid that. So our consultant offered up the possibility of taxing, not putting no level of taxation on the first small increment of gross receipts, and then gradually increasing the rate up through about $1 million in gross receipts, after which the rate would be stabilized. And that's what we did. We also actually said that nobody would pay more tax than their net, or not their net, but their gross profit margin, basically. So you can read that. It's in sections 17, 18, and 19 of the Utah CARES Act, and that is available also on the website, utahcares.vote. You can read the whole act and find section 17, 18, and 19. It'll describe for you how that gross receipts tax is to be implemented. We have agreement from the Office of the Fiscal Analyst at the legislature, having now submitted this all as an application for inclusion on the ballot in 2026. They agree that our revenue projections are correct, that we will raise $10 billion. So we were happy with that. Okay, I think that's pretty much what I was asked to describe, and I'll stop there and let there be time for questions.
Well, thank you so much, all three of you, commenting on different aspects of the efforts to get a state-based health plan. Do any of the interns have any questions that they would like to start off with? Oh, Zachary?
Well, first off, thank you for everyone for sharing where your state's at, specifically in the single payer reform. And to my understanding, it seems like New York is the furthest along in potentially passing bill. So for Mrs. Melanie D'Arrigo, sorry, not a lot of Italians where I'm from. Throughout this internship, we've kind of come to understand the US system as a very complex, multi-payer, fragmented system, and trying to consolidate all of them into one single payer, especially at a state level, seems very complex. And one of the things that we anticipated to be some sort of barrier is, especially with like the federal government, we know that there's more corporate interest in even traditional Medicare through like ACO REACH programs. And then Medicare Advantage plans themselves are completely privatized. I was just wondering how the funding of Medicare would be integrated into the New York Health Act, or if it would remain a separate entity, or what does that look like in New York?
Yeah, sure. So The bill was written in a way where, so let me back up. In an ideal world, New York would apply for a federal waiver, and then we would be able to get all monies going into the New York Health Fund, and we can disperse from there. That would be in an ideal world, right? I think we have a very hostile federal government right now. So, if the New York Health Act were to pass, I don't think any of us are under any illusions of grandeur that the federal government would allow such a waiver. But that said, Dick Godfrey wrote the bill in such a way that even if we were not able to obtain a waiver, we could still move forward with the New York Health Act. And I'll kind of borrow his words since he's the author of the bill. The way he describes it, he says that it's essentially more clunky on the back end, right? So the monies will come in, and it's more processing on the back end. So it'll be, but from a user experience, you'll as a user, you would utilize the plan just as if we had the waiver. It would not affect the user at all. And I think you sort of had kind of a two-part question there, if I'm correct. Part of your question, you asked, how would the Medicare system work, right? So I just want to make something clear. We get this question all the time. Medicare doesn't go away, right? So every person who's entitled to Medicare gets their Medicare. The New York Health Act would obviously beef up Medicare. We have much more extensive services offered with the New York Health Act than Medicare alone. So when I say that, because a Medicare patient would experience healthcare in New York just as every other person. But if that Medicare patient, let's say, decided to move to Utah and they didn't have single payer, or decided to move to Alaska, then they would take their Medicare with them. So I don't know if that's sort of like a very high level way. It can be done. It's clunkier on the back end, but we do have some infrastructure in place. We have expanded Medicaid and things of that nature in New York. So we've dealt with smaller but similar mechanisms.
Thank you for clarifying that. I wasn't aware that applying for a waiver to bypass all of the traditional reimbursement schemes for Medicare was a possibility.
Mm-hmm. Yeah, I mean, so think of it as like the New York Health Act would sort of wrap around those services, and the way it's paid on the back end. Again, it's not as smooth, but it absolutely can be done.
So just to be more clear, does that mean that the patient would go in and see the doctor and walk away, and it would just be like normal for that patient compared to any of the other New York patients? But from the doctor's office, they would send the bill to the state, and the state would bill Medicare?
It's really even more on the state level. The folks that are working on the payment processing on the state level, it would be clunkier there, right? They'd have to figure out how we get payment, but from a user perspective, it would work the same as if you're 10 years old or you're 70 years old. It would be uniform.
From the provider's perspective, the clinician in the office who just saw the Medicare aged patient, what does that office have to do?
It would, just like it would do to any, and again, now let me say this with a grain of salt, right? Because the bill has not passed yet. Right. And our bill, once the bill is passed, it stipulates that a board is developed to really work out all the nitty-gritty details of those questions. So that is not specifically spelled out in the bill. But the way we believe it would work is, they would send it to the state, and then the state would facilitate the payments.
Okay, thank you.
You're welcome. You're welcome.
Natalia?
Hi, thank you everyone for being here. My question is directed specifically at Dr. Jarvis. I grew up in Utah, so it's nice to see a fellow Utahn here. My question is regarding the 24% of the bill that would be floated by larger businesses. It's kind of two parts related to that. Do you know how this amount compares to what those businesses already pay to provide health insurance to their employees? And are there concerns that the gross receipts taxes will be transferred onto the consumer through price increases by the businesses?
The major argument against the gross receipts tax is that it will be inflationary on all kinds of consumer goods and services. Our argument back is that those studies that have asserted that that's the case with the gross receipts tax have been done where the only action was to increase taxation by putting in place the gross receipts tax, and that we're in fact removing a significant cost from the production of goods and services in Utah by removing from the employers through whatever they do to, the wage related costs of healthcare, the healthcare benefit. And we actually had EconoWest study the impact on employers throughout Utah. And with very few exceptions, all employers would end up in a net gain situation. Things would be better for them with implementation than they had been when they were struggling to try to every year find a new, either a health benefit. Most of them don't insure. Most of them actually do a self-funded health plan that is then managed by a usual insurance company. So the exceptions are those large corporations that are nationwide, mostly in the retail sector. Sorry, I'm gonna turn this off. Mostly in the retail sector that are not they're not pulling their weight in terms of providing a health benefit for their employees. The Walmarts of the world, for instance, where employees are either kept from accruing the number of hours they need to qualify for a health benefit, or there is no health benefit offered at all. They end up qualifying for Medicaid often because they're paid so poorly. Those large retailers, and we have them in Utah like every state has them, would end up paying a substantial portion of the gross receipts tax, the 10 billion total that we accrue. And whereas they had not been paying anywhere near that much before. So we anticipate opposition, of course, from that sector of the economy, but Utah has a fair amount of hospitality industry. We're a state that welcomes people for skiing in the winter and for the 5 national parks that are very popular and other tourist destinations in the summer. And the hospitality industry in general would be very much better off. Many of them can't afford, restaurants, for instance, can't afford the benefits, and their employees would automatically be covered under Utah Cares, as an example. So I hope that answered your question.
So their employees would be covered. So it's better for the employees, but the businesses themselves would be paying a whole lot more than they used to because they used to not provide the insurance.
If you're a restaurant that hadn't offered a health benefit, then yes, you're going to be paying more because you haven't been paying anything at all.
Right. Okay, thank you. But if it's a small mom and pop, then it may fit under that number and not actually be paying a lot into it anyway.
Yeah, so again, remember we have a graduated system of gross receipts taxation. The first, I think it's $10,000 is not taxed at all. After that first $10,000, the next 90,000 is taxed at a very low rate. And then a rank above 100,000 to $1 million is taxed at another lower rate.
Mm-hmm.
So it's the people who have gross receipts above $1 million that are the ones and have not been paying for anything for healthcare.
Yeah.
They're the ones that are going to end up paying the most.
Thank you. Thank you. Inanna?
Thanks again, everyone. This question kind of came up in the middle of the talk when Mr. Rico, you mentioned that some labor groups were kind of opposed to what reform you're doing. So I kind of wanted to pose this question to all 3 of you. But what unexpected allies or surprising opponents have you guys encountered as you work for healthcare reform?
Ms. D'Arrigo, do you want to start?
Oh, sure. Yeah. I was just trying to think there. Opponents. Yeah, I mean, I think it is not having all of the labor unions on board is kind of shocking, right? Because I believe that single payer at the heart of it is a labor bill. It's a working class bill. It uplifts working people, makes life more affordable for folks, and gets them the needs and the rights that they deserve, which is really what the labor movement, is supposedly all about, right? So I think that is surprising, but I also think it's shining a light on just how broken down so many of our systems are. And I don't want to shade the labor movement by any means. I think there's still, as a whole, a more functioning unit in society than, say many others. But it's surprising. It stings. That one stings. Frankly, that we don't have, I don't know, like for me, I think Democratic candidates who are out on the trail and they are talking the talk and explaining that they believe in healthcare, that they want to lower costs for people, and then they don't support this bill, like to me is surprising. But on the flip of that, I don't think that healthcare is an issue that is a partisan issue. And it always surprises me that we don't have more Republican candidates out there supporting this bill, because at least, from a New York perspective, the way our financing model works, it would save a considerable amount of money. It would cover everybody. It would lower property taxes. There's so many benefits that are, fit quite neatly in a typical Republican platform. So, I think it's frustrating, right? When we're out there trying to make people's lives better from an opponent perspective. Look, and I think, the hospital industry, right? That's another one that, I think once you've peeked behind the curtain, it makes sense. But, I think for the average person, that would really be shocking, because I think, we understand that insurance companies are very extractive. We understand the issues with pharmaceutical companies, but I think when we think about our hospitals, right, we kind of feel the warm and fuzzies, right? Oh, that's our hospital, it's our local hospital. And of course, not every hospital is the same. We're talking about these mega conglomerates that are eating up all the practices and being extractive that, residents don't see. So that I think, that's one that surprises people as well. In terms of allies, gosh, I mean, this bill makes so much sense to me. I mean, all state payer bills and Medicare for all, for that matter, makes so much sense to me on every level that I don't know that I'm necessarily surprised when we have allies come in. I mean, I guess one thing that has changed recently, right? When the United Healthcare CEO was murdered in my state, in New York City, it was surprising to me to see this outpouring of community responses, right, that were virtually the same, regardless of what side of the political aisle you sat on, right? So we saw folks to the right of Donald Trump and to the left of Bernie Sanders out there expressing disdain with a broken healthcare system, that something had to change, right? And I think those folks, a lot of them, I think we can bring them in. And I think that was a surprise to me when I saw this. I mean, when else is America unified in anything? Very rarely. So that would be my answer.
Thank you. Thank you. And Mr. George, would you like to take a shot at that, of like surprises?
Yes, I think one of the surprises, and because I've spent a lot of time working on finances and how much could savings really be, issues of that. I really wanted to see what voters thought. So in 2019, plunked down $32,000 to commission a poll of Oregon voters. And we ran this poll intentionally to use no partisan language. And that was, it's kind of difficult because healthcare has become very politicized. But in this poll, we got 62% of the people saying that they would pay a tax 2 to 3 times the size of the state government in order to cover everybody. We had majority support in our district 2, highly rural, which voted 2 to 1 for Trump, and yet it's polling almost 2 to 1 for universal care. But one of the difficulties of that poll is that because we designed it as nonpartisan, the Republicans who supported it thought it was a Republican measure. One of the things that's been pointed out is that, okay, so we've got 40% support from Republicans. As soon as the partisan Democratic governor endorses the bill, the Republican support is gone. And the poll showed 62% support from business. Soon as unions support it, that support is gone. So the real challenge is, to me, is kind of remaking the situation where everybody enters the door at once. And so that we have, you know, everybody on the same footing. You know, as a plant manager, I knew that about 700 employees, I knew that if I wanted a major program to succeed, I needed to get the president of the company and the president of the union to walk into the auditorium at the same time, hand in hand. And if one came first, the other was not coming. So, you know, I think we really need to rebuild some of these coalitions. That's my opinion on more common ground, and I think that's what the Oregon poll result shows. Thanks.
Thank you. And Dr. Jarvis?
I don't have the advantage of the many years of coalition building that's true of both New York and Oregon. As I said, we started pretty much after the pandemic and started building a policy first, followed by a fiscal note, and then we actually wrote the legislation. So now we're sort of a single payer health system reform group with a political issue committee, which is what I chair, required in order to run a ballot initiative in the state of Utah in search of a coalition. I know from having spent some time out on the speaker circuit over many, many years in Utah, where we're likely to get the support. But I'd make one comment about labor unions, which are not strong in Utah. The legislature passed House Bill 267 in this most recent session earlier this year. House Bill 267, in effect, denies public unions like the teachers union the power, the authority to negotiate on behalf of their members. It just pulled the rug out from underneath public unions, basically. So what happened in response to that was the kind of surprising coalition and action that I'm hoping to engender for single payer from some of the same people. The firefighters union, the police officers union, the teachers union, and some others got together immediately and began to try to organize to do what's referred to as a referendum. A referendum is a ballot initiative, except it's not passing new legislation, it's revoking legislation that the legislature has passed. That's
What was the not a resolution?
The referendum is a device under Utah law wherein the people can reverse something that the legislature passed. Now, the requirements are much more strict. You have to get all the signatures within a month after the legislation is signed by the governor. And the requirements in the terms of the number of signatures are the same as if you're qualifying for a ballot initiative, with one small exception. You don't have to get the required percentage in all of the Senate districts of the state, but only half of them. So there is that one little give, but otherwise it's a very stringent requirement. And those three unions pulled it off. They got everybody in the state all up in arms about what the overreach the legislature was doing. And they didn't just get the required number of signatures, they got 2+ times the number of signatures required. So many that the opponents to their referendum gave up trying to do what's called the rescission. Rescission is when you call up individual signers of the referendum and ask them to take their name off it because they misunderstood what it was all about. You know, they try to confuse them, and that's a way they keep things off the ballot. Well, they had so many signers that they realized there was no rescission effort that was ever going to make any difference, and they gave up. So I've started reaching out to those very unions, and I've said to them, you are winning. You've got the hearts and minds of the people of Utah. Now, if you really want to close the deal with them, you'll help us get ours on the ballot with yours. They've qualified for the 2026 ballot with their referendum. And I said, now help us get ours on the ballot with you, with yours. And then when you go back to negotiate, you won't have to worry about the health benefits. You can instead deal with wages and with occupational safety issues, the things that really should matter to your membership. And I think I am going to be very surprised if we don't get their help to do that.
Thank you. Thank you. Thank you for explaining. I have been confused on the difference between a referendum and a resolution for a while. So thank you. Caitlin.
Hi. I have a question for Mr. George. I was just wondering, what do you think was wrong with the 2002 proposal, Measure 23, and what do you attribute its failure to pass to? And then just to follow up, what are some ways that this new current proposal in Oregon is different?
Yeah, thank you, Caitlin. Oregon was either behind or ahead of its time in 2002. In retrospect, and in fact, a lot of polls showed that it was going to pass easily with just, like 6 weeks to go. But of course, people who stood to lose, I'll say insurance companies, were able to, when you suddenly move a huge thing overnight, you're going to wake up in a new system of January 1st. It's very easy to sow doubt. And I think something that we didn't respect enough, and I think something that caught Colorado a little bit by surprise, is they hadn't really poked around enough to know how shallow the support was and how shakeable it was. I think, looking ahead for what might make the new Oregon proposal different is to kind of avoid the sudden, 16-18% tax. When I look around, I think the largest tax that any voters have ever voted on themselves was 4%. So, maybe you start with something like a 4% tax that covers all the uninsured, covers anyone with a cancer diagnosis, covers the big scary things, and then that you can begin after you've shown a success that you can phase in more. Is that enough, Caitlin? It was a good question.
Thank you.
Thank you, Natalia.
So earlier, Mr. George mentioned the issue of coverage for individuals who are out-of-state residents and cross into the state each day to work. And so I was wondering, my question is for Ms. D'Arrigo, if the New York Health Act addresses this issue, since New York also has a large population entering the state to work each day.
Yeah, part of not only does the New York Health Act cover every resident, so regardless of your status, it covers everyone who lives in New York. It also covers full-time workers. Being in New York, we have many, many, many folks that don't live here that work full-time here. So as long as you work full-time, you are also covered.
Let me address the same issue from the perspective of a Western state. Utah serves as the tertiary care center for much of the Intermountain West. People come to Salt Lake City from Montana, southern Idaho, Wyoming, parts of western Colorado, eastern Nevada, to get the care that isn't available where they reside. It turns out to be not an insignificant amount of money that's flows through the Utah health system. So whereas our proposal is to cover or include as a member of the Utah Cares benefit package, those who are resident in Utah, and we didn't make any new and special definition for that in our proposed statute. Rather, we just depended on where the legislature had defined that for other purposes. I mean, there's residency requirements to get a driver's license and to get in-state tuition at University of Utah, et cetera. We just turned it over to the legislature to define residency. To get on as a member of Utah Cares, you have to be resident in whatever that definition is. But it does give Utah Cares, the payer, the single payer, the ability to go and negotiate with those surrounding states about how to take care of the people that come from those states to Utah and serve as a revenue source, if you will, for Utah's healthcare system. It actually inures to our benefit financially that is the case. So yeah, that's my observation about it.
Thank you. I think France actually is a country that does that uses medical care as an export for nearby countries. Ariana?
Hello, thank you all for sharing your state's plans. So throughout the internship, we've talked a lot about the high costs that pharmaceutical companies are currently leveraging for many vital drugs. And I'm just kind of wondering, with the passage or potential passage of your state's reform bills, this question is for everyone. Will the reform bill advocate for lower drug prices? And if drug companies don't comply, how does that affect the cost for the patients? I know that from reading a bit about the Utah's financing plan that there is a potential for bargaining, but I just wanted to hear your thoughts on this topic.
Thank you. And I'll add to that question is actually that if a pharmaceutical company says, we don't care that New York is really huge, if you negotiate lower prices, then we'll have trouble with all the other states, or we don't want to have that set as a precedent for a national Medicare for all. So they might choose, even though it's a reasonable price, you might think, they might just choose to not negotiate with you. And so, Ms. D'Arrigo, do you want to go first?
Yeah, sure. So that's actually part of our financing model. We will be able to negotiate drug and medical devices with the power of nearly 20 million folks in our pool. I don't think it's likely. I think, businesses, they exist to make money, right? That's what they're not I feel really confident in saying most businesses are not there for moral purposes. They are there to make money, right? I think it's very unlikely that every pharmaceutical company says, no, I'm not going to negotiate with you. I think it's very, very unlikely. Because again, yeah, it may be that they may make a little less money this way, but laws change all the time and businesses are constantly having to navigate new policies. So yeah, I mean, it's part of our financing model. It's part of our savings, that in the way we make the New York Health Act work. And I think it's necessary for sure.
Thank you. And Mr. George?
Yeah, I'd like to just show a real quick graph of what I see, and I think that what we're aware of in Oregon is here we go. I mean, everybody knows graphs like this showing how much more healthcare costs in the United States. And thanks to a couple of studies, one by Dr. Irene Papanikolaou of the London School of Economics, and also one by Commonwealth Fund, we know that the three approximately equal causes of higher healthcare in the United States are higher drug costs, higher labor costs, higher healthcare labor costs, higher financial administrative costs. So if you really look at a single payer system as by itself, this is the kind of savings that you would hope to achieve if you could get everyone to go through one payer. Even if you lose 10%, you may lose all of your savings because our goal is to get like a hospital to have no billing department. They work on a payment from the state. They don't bill by patient. And so you lose some of that. And we look at the higher drug costs are mostly caused by federal patent law and federal restrictions. So as a state, we can, we figured 1 or 2% reduction in cost, but not more of that. And while I have the floor, I'll just make a point from our perspective that if you this is kind of based on a Colorado study that if you just get a few people on a single payer system, the cost is going to go up potentially by some number of percentage, but takes like 95% participation before you get into the big savings. And so we see including Medicare or not is actually a big deal because we don't think that we would get the savings of a single payer if Medicare was not included. That was the decision of the Oregon task force and the actuarial.
So can you address that question about if you do or don't get waivers? If you don't get a waiver and you don't get a block grant for the Medicare funds, and many of the patients will be over 65 or be disabled, and they go to the provider's office, do you have a sense of how that bill is going to be addressed?
We're kind of all in for getting Medicare, and we don't believe a system would give us the savings we need if that weren't included. The alternative
Whoops, I think you're freezing on us.
is
Mr.
another.
Can you turn off your video and see if that helps the audio? Can you turn off your video?
Am I speaking better?
This is better, yes.
The issue that we found in Oregon and verified by our actuarials is it's not the elimination of private insurance that yields the savings. It is the simplification of the system. As I think it might have been Natalia pointed out, that looking at things like getting all the insurance companies to agree to the very same terms and work through a state clearinghouse might actually save the same amount of money. Failing getting Medicare involved, and Zachary mentioned it earlier, forget the acronym right now, but if you could actually get the state to work as a Medicare contractor to cover all Medicare and to run an Advantage program, that might be another way to get around them. Another thing, a trick could be, is if you want simplification and you can't get around Medicare, make everybody else look like Medicare with the very same billing, and so that you get that simplification that yields the savings. Thanks.
Thank you. And before we go to Dr. Jarvis, did anybody from New Jersey look to see what your bill looks like? I sent a link. Did anybody take a look? So in New Jersey, there's been a bill. It's not been introduced this session, but the two previous sessions. And the bill is basically tell I don't know, you can't do this really, tell tell the Office of Budget Management, but tell the federal government, whether it's Office of Budget Management or the Congressional Budget Office, to look at our state, in this case, the state of New Jersey. These are how many people we have, figure this out and tell us how much you would charge us. And then we'll figure out the taxation to put everybody on Medicare. And I'm like, what? I thought that was a pretty exciting thing to even consider. But anyway, so now I'll go on to ask Dr. Jarvis on that same question about what happens if the pharmaceutical companies will not negotiate prices down and you don't have as big of a buying power as New York does?
No, we don't. We have about the same amount of buying power as the VA system does, though, and they do negotiate a substantial reduction. And by the way, Medicare has been testing one drug at a time, the idea of negotiating a different rate, and that's been litigated and comes out favorably. So I see all the signs. Medicaid programs around the country have been negotiating pharmaceutical prices too for many years now. I see a lot of signs that say we'll succeed at this, and we do plan for some savings. You'll see that identified in Dr. Friedman's report. Some savings for monopsony negotiating power for pharmaceuticals. I'd like to weigh in on the Medicare issue too. We chose to enable Utah Cares, the single payer, to create a Medicare Advantage plan in Utah. I'm on Medicare, and I know that I have chosen not to be on a Medicare Advantage plan for a lot of good reasons. I have standard Medicare with a supplemental program. So you would have to persuade me to give that up and join a Utah Cares Medicare Advantage plan. And you could do that if you were going to give me a substantially better deal than what I'm currently getting, which we believe we can do. So we would create such a Medicare Advantage plan and then go about the process of, and the further thing to say is part of the legislation is that private insurance companies, after a certain date, will no longer be able to offer any plans, Medicare Advantage or otherwise, in Utah. So we won't have United Healthcare mucking up Utah's market with their interests. Instead, the only Medicare Advantage plan will be the one that's offered by Utah Cares.
So here's a quick question is, I didn't think that states could choose to not allow any Medicare Advantage plans because it was a federal program?
So insurance is state regulated. You can't offer insurance in Utah if you don't meet the requirements of the state insurance commissioner. And what we've instructed the state insurance commissioner to do if this were to pass is after a certain date, there won't be other health insurance companies.
Including Medicare Advantage, okay.
Yeah, Medicare Advantage, that's right.
Okay, huh. Ariana, did you have your hand up? Oh, Natalia.
So my question was related to public versus private. I know Utah Cares plans to use public financing to fund privately delivered care, and I was wondering if the plans in Oregon and New York would function similarly, or if they would introduce limitations on private care provision or change the system in some other way.
I'll jump in short and quickly. It's certainly my hope. Well, first, we kind of made some assumptions early on that we were only going to change the finance system. But if we can get to a point where we control all the money to all of the providers, then I would be very happy to be in a position of saying, we don't need more cardiologists in Portland. We need one in Salem or something like that, so that we can direct more. I would think of the model more like a fire department where they want to be within 7 minutes of any call or something like that. So, but unless you can get to that more or less 100% control, you can't behave like that.
Yeah, and at a high level, I mean, the New York Health Act does not interfere with care given by any physicians at all. We're trying to get away from that, right? That's kind of our broken healthcare system now, right? Doctors have to go through step processes, and depending on the insurance, certain care that they would like to initiate is not covered, so they have to, and you'll get to know that very well if universal health care isn't passed where you practice. So our intent is not to degrade that any further. It's to really reverse that and allow the care of a patient to be between them and their doctors. And it's very much like what Mr. George said in terms of we are changing the financing model. It's not a government-run healthcare plan per se, but it is government financed in the sense that we're scooping in these monies, and we're changing the way the delivery model.
Can you tell me whether you have a corporate practice of medicine law in New York right now? Have you heard of that phrase?
No, I can't comment on that. I'm sorry, but I can get back to you, Betty.
Yeah, you see the acronym CPOM, corporate practice of medicine, and those are laws that that prevent private entities from owning or managing, depends on how the law is written, clinicians' practices. And in some states, that doesn't allow any hospitals, for instance, to employ them either, aside from even for-profit corporations that may also prevent hospitals from employing physicians. And in some states, they can, if they're not for-profit hospital, they can employ them, but not if they're a for-profit hospital. So it's different state to state of how, which kind of path they pursue there. But you're not familiar with whether New York has that at all.
Personally, I'm not, but Google just told me that New York has a strong corporate practice of medicine law.
Thank you. And we'll be hearing in detail about what's happening in Oregon in that regard. And Joe, Dr. Jarvis, do you know whether Utah has a corporate practice of medicine law?
We have, I think the answer is no. But the reason I'm thinking that is because we have a very sort of, dominant market system. It's called Intermountain Healthcare in Utah, which is ostensibly nonprofit, which pretty much gets what it wants out of the politicians of the state. And they own and operate lots of clinics. They've been buying out physician practices for many years now. They also have health insurance. They're one of the bigger health insurers in the state. So they vertically and horizontally integrate everything. And they tell doctors how to practice medicine. They tell nurses how to practice nursing. They do, and following closely behind is another large entity, which is the University of Utah Health System, that's increasingly building hospitals distant from the main campus in Salt Lake City. And we've got one for-profit hospital system and another new nonprofit. Those are pretty much the four entities, and they all do the same thing, what you're describing as corporate practice of medicine. So I'd be very surprised if there's something on the books. And if there is, it's certainly not working.
I have any teeth. I am very sorry to my interns. I just looked at the clock and went, oh, it's 2:37. This has been really intriguing to me. I hope the interns found it as intriguing. We have had a lot of questions, so it sounds like they've been gaining a lot. So thank you so much. The interns, we'll be meeting with Dixon Searles Galvez at 3:30. For those who want to attend this elective on webpage design. And the interns are welcome to leave. Those of you who had questions, I don't see any that you put in the chat for non-interns. But well, first let me just give the interns the opportunity to say thank you, wave, and leave if they wish to leave.
Thank you guys so much.
Thank
Get up and
Thank
get your
you.
dog out to the bathroom or whatever. Thank you. Okay, great. Thank you. So did anybody else have questions? Why don't we let Kristen and Stefan introduce themselves?
Great. Thank you so much, Betty. Hi, my name is Kristen Volchansky. I was involved for a little while with One Pair State and a little involved with Healthcare for All PA here in Pennsylvania. I work for a nonprofit advocacy group called Action Together NEPA. I'm based in the Lehigh Valley. Pretty passionate about this issue because I have a genetic immune deficiency myself, so I relied on medical assistance and the ACA. And now I'm back on private insurance. So yeah, it's a pleasure to be here. And thank you so much for this talk today.
Thank you. Thank you. And Stefan?
Yes, hello everyone. My name is Stefan Ramdo, pronounce him. I live down here in Florida, in the Fort Lauderdale area, and I serve currently as the chair of Medicare for All Florida. Also founded the PNHP chapter here in Florida, and I'm one of those national advisors on the PNHP board. And I'm just kind of happy to report, like I made a pitch with Healthcare Now for their national conference, which is going to be in person this year, to be taking place in Florida, and the board considered it, and yeah, actually now kind of they decided on that they want to do that. So Healthcare Now and Medicare for Florida together will be putting on that national strategy conference later this year here in the Central Florida area.
Will that be in the fall or winter, or do you know what month?
It's going to be either the weekend before or after Thanksgiving. So we have to confirm with the venue. But yeah, of course, I would love to see as many of you as are available join us in Florida for the Healthcare Now Medicare for Florida National Strategy Conference.
Thank you. Did either of you have any questions for our panelists?
I mean, I would have one quickly. So yeah, of course, I would love to always hear the updates from Oregon and Utah, but I was also just going to check in with New York because I kind of heard from Dr. Betty Colott. She was kind of down here for a PNHP conference. I mean, it was a physicians conference, but PNHP had a table, and I was there in South Florida recently. But I was just curious, what is the next step in New York? So basically, I know that you're having your New York Health Act, and but yeah, do you know what the next activities are coming up to possibly advance the course?
Yeah, so this is I could spend probably 5 hours going through that. So at a really high level, you know, the bill has been introduced so that it's an active bill right now. As I kind of touched upon earlier, it hasn't moved out of the health committees, and there's a variety, those are external variables, right? And a lot of it is, I think, the political will to do so. We have leadership that really is risk averse, and I think New York, I think things may have changed in New York over the last couple of months, but they had been really suffering from fear of going too left, right? Even in New York. I don't know if you saw the national news, but New York City just had their primary for mayor, and the Democratic Party elected a Democratic socialist. So that is shaking up New York, and it's scaring a lot of this sort of more conservative Democrats. But I think there's this slow wave of understanding that they actually need to address the needs of people. So I think that's good momentum for us. So we're hoping to capitalize on that. We will be rolling out quite a few events and actions. We're trying to tighten up our C4 coalition, kind of the more institutional, powerful groups, right? I mean, there's so many of us grassroots groups that are doing that really important work in our communities, but we need those big, you know, as I like to call them, whale organizations to speak with a unified voice and push more fervently than they have been, right? So I think the appetite has shifted, the political moment is there. So we're hoping to roll out some press conferences, some really strong messaging campaigns on the economics, some storytelling, getting folks involved locally for New York Health Act 101s and bringing them into our regional hub movement. And then we're very likely going to have a special legislative session in New York come this fall. Unfortunately, our governor is not not in alignment with the Democratic nominee for New York City mayor. She sits in the more conservative camp. So what we expect, and the way our special sessions work, the governor presents a plan, and the legislature then gets to debate that plan. But the legislature does not get to bring anything forth, which seems, you know, backwards, but that's the way it is. Nobody expects her to do anything other than kind of shuffle funding around. She's very hesitant to raising taxes on our billionaire population. So she's going to be, she also has a competitive primary. So I think, you know, it's a perfect storm for them, but it creates very good political conditions for us. So we will be using that as sort of our launch pad for intense legislative pressure leading up until our session, which actually officially begins in January. So, you know, my hope is that through all of these initiatives, we'll be able to redirect energy and really target our state government. And then I think, you know, come January, these folks can't hide from us and they, you know, there's no excuses. So then we'll keep turning up the dial.
Wow, wow, that's incredible. I mean, I used to live in Connecticut, and so kind of New York was just a neighboring state, and so I'm still on the campaign for New York Health mailing list, and you know,
Great,
New York Metro, and yeah, incredible all the activities that you have planned and what you're already doing. Like say you had the lobby day in Albany, and you know, it's incredible to see all this. Here in Florida, we're just happy that we have a Healthy Florida Act that we introduced Medicare for Florida, wrote the bill language for it, but yeah, to see how you have, I think, 74 out of 150 assembly members. Well, there's so much support. So
yeah, I mean, but that's the sort of the problem. We've sort of been stuck there for a bit, you know. So we're really in the sense that we've had majority support, and it still hasn't moved. The bill still hasn't advanced due to political reasons. But as I said, I think the political conditions in New York and the political conditions federally, I think, has us. It puts us in a very good position to both bring folks in and apply a level of pressure that can't be ignored. So we're very excited about our momentum and, you know, coming activities.
Thank you. Thank you so much. And Kristen, did you have any questions?
I did have one question, and it kind of jumps off your point, Melanie, about having elected officials at the state level who are hesitant to raise taxes. In Pennsylvania, we're facing a pretty steep structural deficit, especially next year and going forward. And there are a lot of competing advocacy priorities, whether it's transit or it's funding for like the area offices on aging or education funding, because we had a landmark case 2 years ago that found that our state system for funding education is unconstitutional and that the state needs to put more funding into public schools. So I'm curious for folks on the call, how are you interacting with others in the nonprofit advocacy space and working together and potentially building partnerships and coalitions to advance this fight for universal healthcare forward?
I mean, I'm happy to jump in, but I was just speaking, so I want to, you know, offer to the other panelists first.
Well, I think it's difficult. I think in Oregon, there's evidence that unions carry a lot of weight. They've got some bills passed in this legislature, and including one that gives union members unemployment benefits while they're on strike, which would seemingly be quite controversial, but it passed. And in other recent legislatures, unions have a lot of they have worked hard to elect their own into the legislature, and tend to be looking out for their interests. Not everybody would say that's the public interest, but they're very effective at getting things done in ways that Osberg and other organizations just really haven't been. In Oregon, we have a particular problem in that we in 2023 we passed a constitutional amendment that it's the obligation of the state to ensure that everyone in Oregon has access to affordable, clinically appropriate care. But so that's obligation is on the budget. Many people fear that it will actually, it's already, the legislature's already stopped all funding for our public universities, and public funding for our public school system is going down, certainly in proportion as we cover more and more healthcare. So there is really a lot of fear and a lot of heavy thinking about where does this end, and how can we reach some kind of a nice balance. For me, as kind of a pragmatist, I admire Melanie for her being a very enthusiastic person. Well, but for me, the only solution is to get the price down, and to get healthcare more economical. So it solves, it helps get the money back to the schools and other priorities if we can do that. Thanks.
The recent legislation from the federal government has people in Utah fearing about downsizing of Medicaid. The projections are closing in on 200,000 people on Medicaid in Utah will lose that coverage. There's long since been issues related to the disabled community and not being able to get Medicaid financing for the services that they need. And so there's a rising interest in what we're proposing, which is a brand new source of funding for these services that's independent really of the legislature, because we are, creating what we're calling the Utah Cares Premium, which is the gross receipts tax that I talked about earlier, that can serve as the state funds that the federal fund would then be drawn down to support, independent of whether the legislature, which is threatening, if in fact there's a reduction in federal support, there's a trigger law in Utah that will cut off the expansions related to the Affordable Care Act, even though those were passed by ballot initiative in 2018. So I right now I feel like this is one moment where the fears about what's happening in Washington might actually work to our advantage, because we have an idea that nobody else has, that how we can finance this and still draw down those federal Medicaid funds and optimize what can happen in Utah.
And I'll just add, I think every state is facing what you described, Kristen. Every state is looking at their state budget because of this reconciliation bill and looking at the holes and trying to figure out a plan to fix them. And New York is no different. We are fortunate in the sense that this campaign has been around for a long time, and coalition building is part of our everyday work. It's part of our off-year work. We're constantly working to bring in new folks. And we have a lot of organizations that do support us, right? And I think our challenge has been, how do we move them from support to prioritization, right? And that I talked about that earlier with these competing priorities has been tricky for us. I think what helps us in this moment is that coalition already exists. We're already talking to each other. But now healthcare has really moved up the priority ladder because of this federal bill. But that, of course, does not discount what's going to happen to, housing money, education money, et cetera. With our financing bill, it saves, and we're working on some materials right now with our the original author of the bill, Dick Godfrey, to get out to the legislature and our supporters how the savings for the New York Health Act could really make up for a lot of the hole in the budget, even though it's a balancing act, because our financing bill relies on both a progressive tax as well as federal money. So, less federal money obviously shrinks that pot, but the savings are so extreme. The way I explain it to people, it's like, okay, well, we could either have a state where, over 1 million people are kicked off their health insurance, hospitals are closing, ER wait times are going up, everyone's premiums are going up. And have this shortfall, or worst case scenario, we have a much smaller hole in the budget and everybody's covered and all of our hospitals stay open, right? So we're kind of coalescing folks around that, but also, as an organizer myself, even outside of the healthcare space, I think it's really important. I think you touched upon this, that the coalition that we build is in service of all the people, right? So we need to really speak with unifying voices on healthcare, on housing, on education, and we need to drive that together instead of segmenting ourselves into issues and maybe, having to fight for those supporters. We need to get our message together and push for it. And I think, as Dr. Jarvis pointed out, again, the fallout from this reconciliation bill has created that a ground where individuals and organizations need and must act. It's not even a question of should we, could we, they must, right? We're no longer asking for progress. We're now asking for, it's reactive, right? People have to, and organizations have to fight this with everything we have. And the way we win it is together.
Thank you so much. So, I know I had another question, but it's feeling pretty late, so I might send it by email, and I'll wait and see if I get some more questions to share with, from the interns to share with you. I know that some of the questions are related to financing, like if all these different pieces fell apart, if you lose one or two of them, will you still be able to afford it? So I'm going to gather those various questions that were raised this morning. We had 2 sessions this morning, political issues around state-based and economic issues around state-based. So I'll try to gather some of that together too. And you can either, punt it or ignore it or whatever. But those will be some questions that we have out there that I'll share with the interns if you're able to respond. So thank you so much appreciate your time. This is really exciting. Thank you.
I'd like to thank my fellow panelists. Appreciate the time together.
It's great to have you in the same room.
Likewise, good to see you, Warren.
And it's great to see Stefan and to hear Kristen again.
Stefan, likewise. So nice to see you again.
Yes, same here.
For those of you who don't know Stefan, I guess Warren knows him too. But Melanie, do you know Stefan?
I do now. So
we started or restarted the chapter for PNHP in Connecticut, even though he's not a physician. He's like, well, why don't we have one here? And he started one up in Connecticut, got down to Florida, and when he was transferred for his job. And again, it was, had kind of dwindled as people retired and didn't have new people to recruit, and he got that one started up again too. So quite a powerhouse.
amazing.
Thank you so much, everybody.